Phase 3 study is a randomized clinical trial, randomized 1-to-1, so one patient to the new technique, one patient to the standard technique. The new technique, IMRT, is a special technique to improve the dose conformity and the tissue sparing. And the accelerated means each day more dose and less number of fractions.
So you're highly targeting the dose,
Exactly.
but you've also changed the density of the dose.
Exactly in that way, exactly.
So what exactly did you do in this regimen?
In this
Describe
regimen,
the protocol to me.
Yes, in the regimen, the surgeon put the surgical clips on the tumor bed, so you can identify on the CT, planning CT, the clips. So the clips are the tumor bed, and you draw with your hand a volume, means clinical target volume, it is 1 centimeter all around the surgical clips. And after that, another 1 centimeter around the clinical target volume, it's called planning target volume. And you deliver the dose exactly in this volume, only in this small volume, respect to the whole breast.
And in a much shorter space of time.
Exactly.
So what happened in the study?
The study, to be honest, was excellent because nothing happened. And so nothing new is good.
So are you saying that by carefully modulating the radiation to reach the lesion, the bed that was required, and changing the density, had no effect in comparison to whole breast?
Exactly. No effects, but I can see that it's better than the old technique because the cosmetic result was better, was significantly better in terms of skin toxicity and also acute skin toxicity and early late skin toxicity.
Right, so the end point for this was toxicity as quite an important endpoint.
Yes, obviously. The secondary endpoint was toxicity. The first endpoint, the main endpoint, was local recurrences. And at the moment, after with a median follow-up of 5 years, we have the same local recurrences, and it's very important. Obviously, we have to wait. We have to wait more time, maybe at least 10 years. But just after 5 years, the result is the same.
However, acute and late toxicities are looking how?
Yes, exactly.
Is looking good?
Yeah, it's excellent. The worst toxicity was in the standard field, in the standard treatment. The new technique was excellent.
Right. What then would you recommend doctors to be doing from now on with this data?
With this data, I suggest, to be honest, waiting for another couple of years because the big American trial, B39, is near to be published. And so I think that with that study and our study, we can obtain maybe the routine, the change routine. But obviously, B39 is bigger than our study because the study randomized, if I don't make a mistake, around 3,000 patients, and we only 520 patients. So obviously the statistic power is different, but the fact that we obtain a good result is just a good news. So I think that maybe in 1 year we can start to recommend for all of the patients that treatment.
So what message would you give to doctors for the time being, an interim message then, a practical message?
Practical message, at the moment, follow the ASTRO guidelines. And in the next future, waiting for the B39 and consider after that to use the technique that they considered better in their center.
But you're anticipating an improvement in toxicities.
Yes, exactly.